waiting for Dr. Sobel's signal. Okay. So today I'm gonna update you on the glucose continuous glucose monitoring devices and what they mean and what can they do for our diabetes care. So as you all know, since the discovery of insulin by Banting in 1921, we have come a long way in terms of treatment of diabetes. And with that, the picture of diabetes has really changed, especially type 1 diabetes. Oh, nice, sure. Is that good? Okay, you can go. Especially type 1 diabetes has changed from being years and years ago being a serious fatal disease, now a disease that is perfectly manageable and we all know how to take care of it. Unfortunately, we haven't found the cure for type 1 diabetes yet, but we all know how to take care of our patients and have a healthy and happy life with a normal life expectancy. So our famous DCCT trial, diabetes control and complication trial in 1980s and 90s showed that really it matters if a patient has well-controlled diabetes versus if they have poorly controlled diabetes in terms of what they expect for long-term complications. It really matters. And our indicator of the diabetes control, as we all know, is hemoglobin A1C. So just a review of A1C. Glucose in the blood binds to the proteins that are there in the serum. One of these proteins is hemoglobin, which makes our blood red and gives the red blood cells the ability to transport oxygen to the tissues. Glucose plus or attached to the hemoglobin makes hemoglobin glycated hemoglobin or hemoglobin A1C. Non-diabetic people have 4 to 6% of hemoglobin A1C in their blood. And there is a correlation, a direct correlation between the level of hemoglobin A1C and the average blood glucose. In other words, if we have somebody with an A1C of 10 or 11, their average blood sugar is above 240. We know that it matters how well controlled your glycemic control is, and we have definite data that decreasing hemoglobin A1C gives us better long-term expectancy. Our target for treatment of diabetes, as we all know, is hemoglobin A1C of less than 7 by ADA criteria. Other organizations have even lower targets, like ACE, American Association of Clinical Endocrinologists, even aims for a target of less than 6.5. Now, how to achieve this target A1C? We have different types of insulins with different potencies, and we have insulin analogs, the rapidly acting insulins available recently. So the way that we treat type 1 diabetes in our pediatric population, we mainly use one of these three regimens: twice daily or the conventional treatment, multiple daily injections or basal bolus, or the fabulous insulin pumps, which is the treatment that is a lot more physiologic and closer to what the body normally does. Is pump better than injections? Well, we all know patients, we have patients that have excellent glycemic control with daily injections, but it just takes more effort and it's a little harder. Why? We know that the variability in the plasma levels of insulin is much more with long-acting insulins compared to the short-acting insulin, and the kind of insulin that goes to the pump is only the short-acting insulin. So when the plasma level is more steady, you would expect less glucose variability from that treatment. So the data shows that more people on insulin pump at least more easily can achieve a target hemoglobin A1C. But it's achievable with multiple injections or even conventional treatment. Now, we all know some patients that are very religiously taking their insulin. They are checking their blood sugars multiple times a day before they eat. And even on the paper, the records look very good. All the finger stick glucoses are within the target rate, but their A1C is not at the target. And we all wonder what's really happening. So it would be very nice if we had a system that could give us the insight beyond those few glucose readings. So when you have the system available, continuous monitoring of glucose, you see that this patient who happened to have good finger stick readings 4 times a day, most of the night he or she was really, really high. Right before dawn, had really low blood sugars, and each time that he ate, his glucose just surged up really above 200. So no wonder that this person might not be able to achieve a good glycemic control. So what are really our barriers in achieving good control? As we all know, glycemic excursions after meals is a big thing that a lot of times right after meals our glucose is way beyond our insulin action and we cannot catch up with it. A lot of patients suffer from exercise-induced or nocturnal hypoglycemia. A lot of times we see patients that have high blood sugars right in the morning, and I ask the patient to check the blood sugar in the middle of the night to see where we are overnight, to be able to differentiate between these two phenomena. So dawn versus Somogyi effect. You've heard probably of both of them. Dawn phenomenon is a phenomenon that happens in everybody, diabetic or non-diabetic. All of us in early hours of the morning, between 4 and 8 o'clock in the morning, get a surge of counter-regulatory hormones, hormones that counteract with the action of insulin, like growth hormone and cortisol. And basically they bring the blood sugar up. We all know that most of the time our bodies are more insulin resistant in the early hours of the morning, and that's because of this physiologic dawn phenomenon. It's said that this phenomenon was what helped our ancestors to get up and wake up and get up and go out for hunting. So we all have a little bit more insulin resistance in the early hours. So if a patient has high blood sugars in the morning and I suspect that it's because of dawn phenomenon, what I usually do is I raise their overnight insulin. Or if they are on the pump, I just raise the basal rate for those 4 to 8 a.m. hours, the hours that we just need more insulin. Versus Somogyi effect has a completely different management. Somogyi is when your overnight mealtime bolus at dinner or your overnight basal insulin is too much and the blood sugar drops overnight. So you get a low around midnight or 2 o'clock in the morning, and then your body counteracts and brings your sugar up by those counter-regulatory hormones. So the management for Somogyi effect would be exactly the opposite. I have to lower the overnight basal rate to avoid that hypoglycemia. And it's obvious that it would be really helpful if I can get a glucose measurement overnight and see really where we are. So that's another barrier that a lot of times, at least with my patient population, the children, parents are reluctant to raise the amount of the basal insulin because of these two phenomena. And the child comes in really high in the morning, but the fear of nocturnal hypoglycemia kind of prevents the parents from taking the right action. So infants and toddlers would definitely benefit from a system that can unmask those hypo or hyperglycemic events that we cannot see with finger stick measurements. Hypoglycemia unawareness is another entity when you have had poorly controlled diabetes. Your nervous system may not respond as normal to a low blood sugar. So these are patients that their blood sugar may drop really, really low, and they just don't get shakiness, they don't get dizzy, tremors, and you see like glucose is 20 or 30 and they're about to have a seizure, but they are just unaware of their low. So that would be really nice if we had a backup system to show us really what the glucose is running at the moment. And gastroparesis is another entity that when you, the function of the gastric, the stomach nervous system has been affected by the poorly controlled diabetes. Those are patients that they have very delayed gastric emptying time, and from a meal at bedtime, they may get very high blood sugars overnight. Again, unmasking those highs would benefit these patients. So, I hope that I've convinced you so far that a continuous monitoring system will really help us and our patients. So the very first system that was introduced in late 90s was a kind of blind system. So it was a monitor that the patient would wear for 2 or 3 days and would not show any of the readings, just would keep records of the blood sugar readings. And after 3 days, the patient would bring the monitor to the office and we would download those, and retrospectively we would look at those records and would make decisions and adjustments. So it was really helpful, but it wasn't ideal because it wasn't interactive. The patient was not aware of what was going on at the moment. It wasn't a real-time system. Even with that, when I really like this study because it looks at some good patients with a very normal hemoglobin A1C at target that were supposed to have good control, good glycemic control. So their average A1C